Hello and welcome to another of our series of conversations. Today I have my esteemed colleague, Dr. Susanna Park, and today we're going to talk about female PreCycle testing. We've done topics already on other topics, for example, male testing. If you want to listen to that, please go to our YouTube channel. But today we're going to focus on female PreCycle testing. Good afternoon, Dr. Park.
Good afternoon. It's good to see you again.
Likewise. So PreCycle testing for females, can you tell us a little bit about what that is and how it can differ depending on circumstances?
Absolutely. So there are two things at play here. One is, are we going to be using your eggs? And the second question is, are we going to be using your uterus? So if we're going to be using your eggs, regardless if it's going into your own uterus or somebody else's uterus, we need to make sure that we get an idea of your egg quantity and your quality, because that drives a lot of the success rates of most fertility treatments. So there are a couple egg tests, and they can be classified into three different tests. And one is a blood test called anti-Mullerian hormone. The acronym for that is AMH. And AMH is a blood test, and it's an exact number, and you want it to be generally above 1 nanograms per ml. The metrics in Europe are a little bit different, but it's easy to convert. And even though it's a quantitative number, it's a qualitative assessment of how many eggs you have left in your lifetime supply. So remember that men, you guys make sperm all the time until the day you die, and women don't. We're born with our lifetime supply, and by the time we hit menopause, which is usually the age of 50, we've run out of our eggs. So the AMH gives you an idea of what's left in that lifetime supply. The second blood test is called follicle stimulating hormone, and you should do this along with an estradiol. And this one is specific to menstrual cycle. And generally you want to do it on the second or third, sometimes fourth day of your cycle. If your FSH level is greater than 10 milli-international units per ml, it usually signifies that your ovaries are starting to age. And the third test is an ultrasound for something called antral follicles. Now, the first test, AMH, and the third test, antral follicles, it does not matter where you are in your cycle. So antral follicles are that every month, it's a very common misconception. People think that one egg grows big, one egg ovulates, and so you just lost one egg, right, from your supply. That's actually not quite accurate. So from your limited lifetime supply, every month, a cohort of eggs starts to grow big. And that cohort is your antral follicles. And because we can't see your lifetime supply, we know that the more antral follicles we see in a month, it means that you must have a pretty abundant lifetime egg supply left. Conversely, the less antral follicles you see in a month, the less eggs you must have left in your lifetime supply. So the first test is a blood test, anti-Mullerian hormone. The second is also a blood test specific to menstrual cycle days 2, 3, 4, follicle stimulating hormone and estradiol. And the third is an ultrasound for antral follicle count. So these three tests give us an idea of your prognosis for success. Now, if you're going to be using your own uterus, we need to make sure that you're going to be healthy enough to carry the pregnancy. Okay, so that's going to be medical tests such as, is your thyroid okay? Is your prolactin level okay? Prolactin is a hormone that, if elevated, may increase risk of miscarriage. Number 3, what's your blood type? 4, are you diabetic? 5, what is your infectious disease status? So we do an array of different infectious diseases. 6, are you immune to different conditions? So we check for immunity to rubella, immunity to chickenpox. 7, what's your vitamin D level? There are multiple studies showing that low vitamin D levels may have a negative impact on your fertility.
I did not know that, but then why would I? So a question for you, if you have, for example, been with a contraceptive device, like an IUD, does that increase, does that stop your lifetime supply of eggs being used up? And would that have had an impact on somebody's fertility?
Correct. So it's a common question. So the IUD works as a physical obstruction in your uterus to inhibit the mobility of cells to move up into the fallopian tubes. And it also creates just a negative environment. So it also inhibits implantation. Now there's some IUDs, like in the United States, we call it the Mirena, that has a hormone in it, progesterone, and that inhibits you from ovulating. So IUDs do not affect your egg supply, but they do create a thin lining in the uterus while it is in place. Now, most IUDs, when you pull them out, will not have a negative impact on the lining of the uterus, but they can. There's another IUD in the United States called Paragard. That one has no hormone in it. And on the Paragard, you still make a thick lining every month and you still shed every month. So that's less likely to have an impact on your lining. But IUDs that tend to have progesterone in them will keep your lining thin. Again, that's part of its efficacy. But sometimes we do notice that even after waiting 3 months or 6 months, even a year, that lining never quite bounces back. So it may and it may not.
And I guess back to what you were just saying, there are women who are going to be using their eggs and then having a surrogate to carry, or there'll be women who potentially will be using an egg donor and then their uterus. So can you give a little bit more about the women who are going to be using their uterus, and it could be their eggs or a donor egg plus IVF, and what types of uterine evaluation would you be doing for those women?
So we need to make sure that the uterus is capable of carrying. And many people confuse a regular ultrasound with other tests. So when you do a vaginal ultrasound, that means the probe goes inside the vagina. But all you're capable of looking at is the musculature structure of the uterus. You can also see the ovaries. But when you are pregnant, what you want to know is the inside space of the uterus, and in medical terms, we call it a potential space, meaning that it's a collapsed uterus, but if you put something inside, it will expand. So the question is, will that potential space inside the uterus be capable of carrying a pregnancy? And on an ultrasound, because it's a collapsed space, you don't know the answer to that. Now, sometimes I've seen big fibroids or polyps inside, even though it's collapsed, simply because it's huge. And I mean, how could you miss it? But there are small things that you won't see if it's a collapsed space. And for that reason, you need to do some kind of test to expand that space. And usually we use saline, so salt water, and to make that space open, and then you do an ultrasound. So there are different names for it: sonohysterogram, saline sonogram, sonography. They all mean the same thing. Some centers will use a hysterosalpingogram. That looks at the uterus and the fallopian tubes. But whichever test you choose, you need some kind of test to expand that potential space. And then you can clearly see if there are any fibroids or polyps, or perhaps you have scar tissue there from a prior pregnancy or a prior instrumentation of the uterus. So it's important you make sure that that uterus space is normal.
And then what can be done if there is a polyp or a fibroid, and how often do they reoccur?
Great question. So if you do have something inside the uterus, it's a rather simple surgery called a hysteroscopy. Hyst meaning uterus, oscopy meaning camera. So under anesthesia, a camera is slid inside the uterus, and whatever's in there, polyp, fibroid, scar tissue, can be removed. It's a pretty simple surgery. It's outpatient, 45 minutes. It's quick.
And the recovery time, and can they reoccur?
The recovery time is pretty rapid. It's rare that you need strong pain medication afterwards. Usually Tylenol or ibuprofen should be sufficient. Can they recur? And the answer is, it depends. So polyps do tend to recur more often, as do fibroids. Scar tissue really depends on the situation under which it was performed. But this is why we like to make sure the uterus is normal, not years before your procedure, but really a few months before your transfer to minimize the risk of something recurring.
You're basically trying to make that uterus the most optimal environment to receive the embryo.
Correct.
Okay. And say, for example, I were 40, 45, are there any additional tests that I would need to be doing compared to a 28, 30-year-old?
There are. So when you become older, especially in your mid-40s and older, as with everybody, right, your body's just not the same as that of a 28-year-old. And generally, right, the organs that...
Oh, don't we know that?
You don't know what it's like, right? So the organs that really start to age really are your heart, right, your lungs. So pregnancy itself is really a stress on your body, because when you're pregnant, we call it the intravascular volume. The amount of fluid that your body has to circulate increases significantly. And so your heart has to be in tip-top shape to be able to continuously circulate this volume. Your lungs have to be in tip-top shape to be able to oxygenate this volume. So in addition to making sure health-wise you're okay, in addition to making sure your thyroid is okay and your uterus is okay, we also need to make sure your heart and your lungs are okay. So you then have to undergo special heart and lung tests to make sure that they're capable of carrying this extra load. But being older also means that while pregnant, you're at higher risk for certain conditions such as diabetes and high blood pressure, increased risk for bed rest. You may have to have, because if the medical conditions exacerbate, you may have to have an earlier delivery. So the other issue we mandate is that you actually have a consultation with a high-risk obstetrician who will explain to you all the risks. And again, their job is not to discourage you. Their job is simply to inform you so that you can make a good decision. So you know going into this what risks you have. And honestly, Richard, if you're healthy, it's not often these risks happen, but it's important to know what could potentially happen.
Right, and again, coming back to the reason A, why we're doing this video, but B, a lot of what we at the San Diego Fertility Center do is we're educating so that our clients can they're empowered to make those choices that are right for them, right?
Absolutely, it's all about informed decision, absolutely. Knowledge is power, right? Absolutely.
Right, absolutely. And so then let's kind of go back. You mentioned beforehand that we'd do a panel of STD testing. I guess that would be the same for either using a surrogate or using an egg donor. How does that work?
Correct. So if you're using, for example, let's say you're using just an egg donor, right? Then you are receiving these eggs from a donor. Well, we've already tested the donor for a bunch of different infectious diseases, which would be like HIV and hepatitis B, hepatitis C, and syphilis, and cytomegalovirus, gonorrhea, chlamydia. And you're receiving that tissue which has already been screened. But now let's say that you're using either somebody else's eggs, your eggs, but that tissue is going to a carrier or surrogate. Well, now your tissue is going to somebody else with whom you're not intimate. And the sperm source, let's say you have a male partner, their tissue is also going into this surrogate with whom he's also not intimate. So they're very strict FDA rules to try to protect the surrogate from acquiring an infectious disease inadvertently through this treatment. So in the United States, the FDA mandates that there are certain infectious disease testing, and they also add like West Nile virus to their panel, that must be performed at an FDA-approved lab, which tends to have very high sensitivity to make sure these tests are negative. So our advice is people do a dry run of these labs in whatever country they live in with their primary care doctor. Okay, so you could do it in Europe, you could do it in whatever city you live in the United States. let's make sure that any treatable infectious diseases are detected and treated before they have to do the real FDA tests, okay? Because when you do the real FDA test, that's when we need, if it's the sperm from the male partner, if it's the eggs from the woman. And if any of those FDA tests come back and they're not normal, then the sperm that we got at that time or the eggs we got at that time will not be usable. And it's just a frustration. It's just a waste of money, waste of time. And so we advise people, do a dry run of these tests in your respective cities, countries. And once negative, then let's do the real FDA blood work with the sperm and the eggs, so that when we transfer into the surrogate, we followed all the FDA rules and done our best to ensure the health and the safety of the surrogate.
So then if it's a heterosexual couple using their eggs and their sperm to be carried by the female, do they need to do that testing?
Correct. But if it's carried by the wife, you mean, or by the surrogate? Oh, by the wife? They do not need to do the FDA testing. They just need to do the regular test with their primary care doctor, and that's sufficient.
So it's only if they're using an egg donor and the egg donors use that, the husband wouldn't necessarily need to do, or the partner wouldn't necessarily need to do the testing, because the egg donor's done it, we use the sperm, and then she carries. But if we're using her eggs and his sperm to create an embryo to go into a surrogate, then they both need to do that testing.
Correct.
Okay.
Correct.
And then very briefly, so we've touched on the hormones, we've touched on the testing of the ovaries and the uterine lining, we've touched upon the FDA testing as well. Can you give us a little bit more information on things like the genetic testing that is required?
So whenever you combine any egg or sperm combination, it's strongly recommended that we ensure that there are no DNA mutations. So let me step back just a little bit to explain. So we get our DNA from our egg and our sperm source, and it doesn't change with time, right? So it's the genes that determines how tall we are, our hair color, our eye color, and no matter how old we are, it's your DNA, and that doesn't change. And people get this confused with chromosome testing of the embryos, right? That does change with time, because when you put an egg and a sperm together, the number of chromosomes may change just based on the age of the egg and the sperm source. But we're not talking about number of chromosomes. We're talking about the actual DNA that you possess that you would then pass on to your offspring. Well, we all have mutations in our DNA. It's just part of being human, but look how normal we all are, right? So a lot of these mutations don't mean anything clinically, but sometimes they do. So for example, 1 in 25 Caucasians is a carrier of a disease called cystic fibrosis. And if you have one mutation, generally you have no symptoms. So you have no idea you have this mutation. So what if we combined that sperm with an egg source who also was Caucasian and also happened to be a carrier for cystic fibrosis, but we don't know because she also has those symptoms? Well, now, if you've passed both mutations from the sperm and from the egg to the embryo, that embryo now who has double mutations will be affected by the disease. And we call this autosomal recessive. So we do our best to try to prevent this. So what that means is when you are combining egg and sperm, that we strongly recommend DNA testing of both the sperm source and the egg source. And this can be done very simply with either a blood collection, or we can just send out kits and you just put your saliva into the kit. And with the saliva sample, we can run for various tests for various diseases. But here's the tricky part, Richard. So technology has changed so much in only a few years, and it's changing so rapidly. So 17 years ago when I started this, we never did DNA testing. 7 years ago, we were testing for 2 diseases. Now, companies are capable of checking for nearly 300 mutations. And in 3 years, that panel is just going to be much, much bigger. And so keep in mind that when you do these tests, it is not comprehensive in that there are thousands of mutations that we're just not capable of checking for. But it's a double-edged sword, Richard, right? Because that means, and you know, this has happened to our patients already, that you do a cycle in 2017 and the sperm source and the egg source don't seem to have a match. Now in the year 2020, the panel has expanded and now we realize, oh goodness, this egg donor is now a carrier for this new mutation we're capable of checking for, but we didn't know back in 2017 because we just didn't know about it, so we weren't capable of checking for it. And so now we then have to contact the sperm source from 2017 to inform him that your donor has this mutation that we didn't know about in 2017. Now we're aware of it. You may want to get tested. And this is going to be ongoing as the technology keeps advancing.
And is this the same as 23andMe?
It's very different. So 23andMe figures out your ancestry, right? What countries your bloodline is from. But they do provide at the end of the report, you know, a few diseases that they screen for. But it's just a few diseases. These DNA mutation companies that we work with, they test for many, many more diseases, so it's much more comprehensive. So 23andMe is not a substitute for these DNA mutation tests.
Okay, brilliant. Well, Dr. Park, incredibly informative. Thank you very much. And of course, if anybody has any questions on female PreCycle testing, please do not hesitate to get in touch. Thank you very much.
Thanks. Bye, Richard.
Bye-bye.